So good afternoon, everybody. And at the outset, I'd like to thank Novartis for this invite. So in the next few minutes, I'm going to take you through diurnal management of intraocular pressure in clinical practice. So glaucoma, an emerging peril. If you look at that, the number of glaucoma people is increasing, 12 million cases in India, and 90% of which is undiagnosed. So elevated intraocular pressure is currently the only known and modifiable risk factor for glaucoma. Higher diurnal and nocturnal fluctuations in intraocular pressure have been reported in glaucoma patients, and lowering intraocular pressure by 30% in patients with glaucoma reduces progression. The risk of progression is lowered by 10% with each 1 millimeter of mercury of IOP reduction. IOP peaks during the nocturnal period have been observed in healthy individuals as well, and patients with ocular hypertension or untreated glaucoma measured in the sitting or supine position. Asrani et al. Found that short-term daytime IOP fluctuations measured during home tonometry could actually be a risk factor for progression in those where we find the glaucoma is controlled. So post hoc analysis of patients in the AGIS study revealed that IOP fluctuation between visits over at least 3 years was an independent risk factor for visual field deterioration, and for each millimeter of mercury, the increase in fluctuation increases by 30%, as I just told you, and the long-term prospective study with a 10-year follow-up, it was found that IOP fluctuations in patients of ocular hypertension were the predictors of conversion to primary open-angle glaucoma. Other studies have also shown that relation between IOP fluctuation and glaucoma progression. So the factors which affect intraocular pressure, the general factors are diurnal variation, which I just told you about. IOP is higher in the morning versus the afternoon, and again higher at night than in the morning. Postures in the supine position is the highest compared to the sitting position, and exercises like isometric exercises can increase intraocular pressure. Systemic factors like Valsalva increases intraocular pressure, certain food and drinks increase intraocular pressure, and general anesthesia, ketamine and succinylcholine may increase the intraocular pressure. So if you look at the diurnal and nocturnal variations in intraocular pressure, these are the studies which were conducted as early as the 1898, where they did say that intraocular pressure had great fluctuations throughout the day and in different positions. So intraocular pressure fluctuations throughout the diurnal period, if you look at that, nocturnal supine intraocular pressure was higher than the diurnal IOP in patients with glaucoma and healthy adults. So you look at that graph out there, and those triangles that you see are the glaucoma patients, the colored triangles, and the circles that you see are the healthy controls. So if you look at this part, the point is not working. So if you look at basically the center at night, there you see both the healthy individuals as well as the glaucoma patients had higher pressure than they did during the daytime. So the need for diurnal intraocular pressure measurements. So you could see that a patient is stable, but then there is progression on your fields and OCT. So IOP peaks during the nocturnal period. Clinicians usually assess IOP and therapeutic efficacy of IOP lowering agents during office hours. Single IOP measurements in the sitting position during the normal office hours do not reflect the true range of the individual's IOP, and peak IOP or variations during the day could actually cause the progression, and 24-hour IOP monitoring studies have shown that higher peak pressures and wider fluctuations in IOP were observed outside the typical office hours. So the benefits of diurnal IOP measurements in patients is detection and risk progression. So aggressive IOP lowering therapies can be started, and analyzing a 24-hour IOP curve can actually reveal the higher peaks and the wider IOP fluctuations which occur outside office hours, and a study has been done and found that this led to immediate change in therapy in over 1/3 of patients when you know actually what is the time that the IOP is fluctuating or rising. So the benefits of diurnal IOP measurements in glaucoma patients: First, you have the individualized management, where the response to IOP lowering medications varies from patient to patient and may reduce the rate of change in glaucoma and improve treatment outcomes. Then the improved adherence, you need to give chair time to your patient to explain that IOP is not a constant factor. It does vary with time and with position, and you need to adjust your doses likewise. And behavioral changes, certain occupations and patterns actually do increase IOP. So treatment options to lower intraocular pressure, treatment is to lower intraocular pressure by 20 to 30% from the baseline values. So you have the medical therapy, you have laser trabeculoplasty, and you have trabeculectomy, the gold standard, followed by the glaucoma drainage devices. So what do guidelines recommend? First choice of monotherapy, always start with one drug, never with two drugs. The commonly used monotherapies are generally the prostaglandin analogs because they provide a 24-hour control. If it works, that's very well for the patient. You just need to put the patient on follow-up and see the patient at regular intervals. If it doesn't work, then you need to substitute that and finally add a second drug for achievement of target intraocular pressure, and then again the patient goes on the maintenance therapy. Again, if it does not improve with that, when you switch the monotherapy, then you need to consider, which monotherapy is effective, and then again go on to the second line. But always remember, never give a combination drug or two drugs at a single point of time, because you do not know how much each drug is going to lower the pressure. So the efficacy of different regimes for primary open-angle glaucoma, a meta-analysis showed that prostaglandin analogs provide the best intraocular pressure lowering effect amongst all monotherapy regimes. So if you see the comparison of the PGAs in diurnal IOP control out there, you have travoprost, latanoprost, and bimatoprost, and they almost all have the equal efficacy. Bimatoprost and latanoprost show maximum loss in efficacy in between the 18 to 24-hour period dose, whereas travoprost did show an effect there. So quality use of fixed combinations. You have certain fixed combinations which you can use that makes it easier for the patient to install, and it's easier to keep it in one single bottle and use both the drops at the same time. They generally have the same efficacy if you're using two bottles in two different times. So fixed dose combination with timolol, if you have a look at it, timolol actually has low additivity to the prostaglandin analogs. However, the highest additivity it does have is to travoprost. If you see out there, that's 34.9% that is there, whereas the rest are much less. So this study was conducted to see the combination drugs which is the best. So brinzolamide and brimonidine, it's a pioneer study done, and we were one of the centers who conducted the study in India, and it was a double-masked, randomized, multicentric, active control parallel group study. And at month 3, if you see out there, there was a reduction of 37.6% of mean IOP with this suspension of brimonidine and brinzolamide. So the fixed dose combinations actually did well, and if you have a look there, you have first on your extreme left timolol, the pointer is not working. On your extreme left you have timolol, then you have the fixed dose combination, and then you have the fixed dose combination compared with timolol. So if you look at the nocturnal intraocular pressure and the p-value there, so the red box that you see out there actually shows you that the fixed dose combination actually had a much better effect, more significant than as compared to timolol. So when to consider surgery? Surgery is generally considered when all medical treatment fails. And if you look at that graph out there, it has been also published in this study that trabeculectomy does provide a statistically lower mean IOP and the range of IOP for 24-hour control in a day when the maximum medical therapy fails. So in summary, basically intraocular pressure tends to fluctuate throughout the day and over longer periods. Larger long-term IOP fluctuations are associated with progressive increase in the visual field deterioration. Therapies increasing outflow appear to be better for stabilizing intraocular pressure than those reducing aqueous production. So there you have uveoscleral agents like prostaglandin doing better than timolol, which reduces aqueous production. Greater attention is needed to understand the efficacy of glaucoma therapy for providing diurnal intraocular pressure control. Prostaglandins have shown proven effectiveness in diurnal IOP control, and when prostaglandin analogs are contraindicated, fixed dose combinations like brinzolamide brimonidine can help achieve the diurnal IOP control. Thank you for your attention.